Thanks. I think Dr. Cam Kalantar very rightly put it up that the World Kidney Day tells us, how to live well on with kidney disease, and in which case it has become a patient-centric method of treating CKD, and which is why we thought it will be best to bring in patients also in the panel discussion. Otherwise, it becomes only nephrocentric, nephrology-centric, or a nutritionist sense. So we have a galaxy of speakers here, and let me introduce one by one. Dr. See, he's almost, I mean, he's not a doctor, but he's learned so much about nephrology now that it comes from my mouth. So Kamal Shah is a co-founder of NephroPlus Dialysis Centers, but here the introduction is basically he's almost 18 to 20 years having CKD, has gone through conservative treatment, transplant, peritoneal dialysis, and hemodialysis. He's one of those experienced patients who has seen it all and who knows the ups and downs of each therapy. Let me also introduce my other patient, and both of them are my friends. Samir Haladi, who is the program director of Amar Gandhi Foundation, and we both are, a part of the Amar Gandhi Foundation. He is by profession a digital marketing strategist, and again, importantly, almost 17, 18, 19 years of handling his CKD, conservative management, dialysis, and now transplant. So again, an experienced person. Professor Anita Saxena, we all know, the professor of in the Department of Nephrology, SGPGI. Sana Saigira, we have again heard her and seen, and she's a renal dietitian at Dr. Kriplani's Kidney and Blood Pressure Clinic, and I've always found her extremely, intelligent answers, and always to the point and very practical, the way Dr. Kriplani is also very practical. And Arvind Kanchi would be representing the nephrology community. He's a nephrologist and transplant physician, Bangalore, Sagar and Trustwell Hospitals. And we all know him through the great work he does through the social media. So I think it's time, we have up to 1:30. And before that only we'll try and stop. And of course, Zamrud is there with me. And how can I do this conference or this panel discussion without Zamrud? So let me share the screen. Normally don't have in the panel discussion any slides, but this is basically to just keep the focus on the topics and we don't lose on these topics. So the first thing is, are we too restrictive with renal diets? And what are the effects on quality of life and lifestyle issues? Both these issues would be important from the patient's point of view. But let me tell you what all we are going to cover in this panel discussion. And if yes. So the discussion points will be the patient's perspective, identifying their issues. What are the effects on the, the frustrations, the depressions, and the issues of lifestyle and, quality of life. And then we'll go through the science behind restrictions. Why are the nephrologists and the nutritionists talking about restrictions of these items? And are there any Indian perspectives to it? Is there differences between the Western model and the Indian way of treating CKD, or our diets are different? And then, of course, the more important, because this is a science conference, so we'll talk about proteins, potassium, phosphorus, salt, fluids, calories, and what are the issues behind it. The problems of our kind of patients, why our Indian patients have different issues, and the ill effects of, anybody and everybody advising them, the non-dietitians advise, and so on. And of course, then what is the practical take home? How do you plan parties and get-togethers and outings and festivals? And what are the snacking options which these patients are missing? And eventually to conclude that it's not a one-size-fits-all template of the disease. So, Samir, you are our opening batsman. And again, Kamal, both of you all have to handle this, the two aspects. What are the problems of diet which irritated you as a CKD patient?
So
Samir
let me
Kamal,
take,
yes. Yeah,
as an opening batsman, let me first
yes.
take guard. And
Yes.
so my first experience as a dialysis patient was, as a CKD patient was pre-dialysis. So at that time, there were a lot of protein restrictions, and there were times when I was told not to even have, say, besan or that kind of a thing. So it
Little
was very
louder.
difficult.
Yeah.
Okay. So it was very difficult to even avoid things like besan because it has protein. And yes, dal, for example, was very difficult because patla dal, when we are having rice, then dal, you need some taste. And I was a big eater. I think I still tend to be a big eater, and no, because of all of this, it became very difficult.
Okay.
Typically, even things like, say, chocolate. Okay. So chocolate is something, I guess everybody loves chocolate.
Yes.
And
I was about to tell you, you are not to be blamed for it. Everybody is a big lover.
Thanks for that. That makes me feel so much better. But yeah, there were a lot of restrictions. See, salt, for example, I could manage. I knew it was very critical for me. So I really cut down on my salt, and it really helped me a lot. Fruits is not something that typical middle class people would have on a daily basis. So again, that is something that I could do without. But to have a total ban on something like besan or patla dal was the worst thing that I could go through.
Yeah.
I guess pre-dialysis, that was it. On dialysis, I think I'm a vegetarian, so having so much of protein in a day became extremely difficult. Yes, I subsequently started having eggs, but even then, and I'm a well-rounded personality, as you can see. So, and one egg white is just around 4 or 6 grams of protein. So to really have that kind of protein in a day is a big challenge, and especially when on dialysis you cannot have sprouts or any other source of protein because it is high potassium.
Yeah.
So, that is where I found it difficult. Again, I always had a very active lifestyle. So I used to hike and I used to do photography. So there were times when without salt, I went for hikes. And there was a time I actually fainted on a hike. Okay. So then I tweaked my diet and I sort of learned things all by myself and learned how to adjust the sodium controls on a dialysis machine and carry salt with me, identify what are the symptoms of low salt vis-a-vis what are the symptoms of low sugar. So all of that happened later, but I think these kind of guidance would make a lot of difference.
Yeah. So you try to educate yourself. Kamal, are you there? I can't see you.
Yes, doctor, I'm there.
Yes. So was there any moment when you said to hell with the nephrologists and the dietitians, I will eat what I want? So what are your thoughts on dietary problems as a patient?
Yeah,
does frustration come in sometimes?
Absolutely. I think it does. And that probably happens with most dialysis patients. I was told that you can have only as much water as you need to swallow your tablets. To that extent, the fluid restriction was put. But I think one major change in mindset that I would request nephrologists, dietitians, and so on is to give workarounds rather than restrictions, right? For example, like water, right? We know that dialysis patients need to restrict water to 1 liter. How about giving some ideas on how to restrict, like for example, have a spray bottle or lime cubes.
So Kamal will come to the therapy, what to be done.
Sure,
but I just want to know right now what frustrated you.
Yes. Yeah. So blanket restrictions: drink only that much water, no fruits, milk and milk products should be restricted. And protein, my complaint was that I was told to have high protein, but almost every source of protein had high phosphorus or potassium. So how am I supposed to manage my protein intake when there are so many other things that will go up if I have that protein, right? So those kind of problems I had where I didn't have any guidance on how to manage. I was told that you need to restrict this, you need to restrict that, and as a result, what happens is so many things are restricted, you can start feeling depressed that what the hell is this life? I mean, why continue to live if there's so many restrictions that you can barely eat or drink what you want to, even things like water. Like, I mean, it's not alcohol, right? It's not whiskey that I'm having. They're not saying that have only this much whiskey. It's water. I mean, the thought that I had is restrict even water, something as basic as water. I mean, like, what the hell, that was the thought I had in the initial days.
Yeah, so we'll come out with a case, but this is not meant for people like Dr. Anita Saxena, Zamrud, Sana. They are the ones who, are very knowledgeable about what should be given. But there is a whole community of dietitians who are actually practicing, and it's not that patients go only to corporate hospitals or teaching hospitals. And which is why I congratulate Anita and the SRNMCON for bringing out such conferences and meetings. So these are the people for whom this case actually is representative of as to the frustration of it. So 45-year-old female Mrs. Camila Fernandez underwent general health checkup for weakness and tiredness and was found to have a creatinine of 3.2 milligram per cc. Her urine routine showed trace albumin, rest of it was normal. Sonography typically showed small shrunken kidneys. She used to consume a lot of NSAIDs for chronic migraine. So no medals to diagnose this as, clear-cut CKD. BP was just 130/80, no swelling, good urine output. Nobody would, look at her and tell you she has CKD. BMI was 24, sugars, electrolytes, cholesterol, everything normal, calcium phosphate normal. And her nephrologist typically prescribed her soda bicarb, vitamins, and some advice regarding how to avoid nephrotoxic drugs and referred her to a dietitian. Now, dietitians, of course, they have been also taught a few things about, how to manage CKD, but that's in the general dietetics course, or, like how family physicians are given a general idea about nephrology, not specifically. So her GP referred her to his standard general dietitian. So this is the diet with both the GP and the dietitians typically got together and prescribed. They had a little idea that protein should be restricted, salt should be restricted, potassium should be restricted in CKD diet. So her non-veg was stopped. She was Camila Fernandez. So non-veg was stopped. She was allowed moong dal, tuar dal. 2 dals were allowed, and they were really kind enough to allow her 2 dals. Instead of chapati, she was asked to take rice, bhakri, and as part of protein restriction. All green leafy vegetables were stopped, and she was, of course, allowed to eat dudhi, turiya, gourd, tandi, etc. Fruits which we generally give it to sicker patients. And she was given 2 fruits, papaya and apple. Salads once a week was given, ek chutti holiday ke din aisa salads were allowed, and obviously no coconut water as part of potassium restriction. Her salt was reduced to just 2 grams, and she was allowed 1 liter of fluid. She was given 1 liter of fluid restriction. Obviously no fried food, bakery products, and no dietitian worth her salt will allow so much of bakery and things like that. So whoever took the name of dry fruits was given capital punishment in that house. So there's no question of giving dry fruit. She was asked to eat khakra as a snack, and whenever she felt hungry in between. And of course, she had to Google what a khakra is and how to eat on earth khakra. And she nearly choked reading her prescription. So, Sana, again, I'm not seeing you. What's the problem?
Sana is there?
Yes, I'm there.
Yes.
I'm there, sir.
So we had to call experts to, modify this diet. And Sana, how would you treat Camila Fernandez?
Okay, thank you for the introduction, sir. Well, like you said, Camila Fernandez, when I listened to this, and stopping non-veg is like a crime for Camila Fernandez. So the first what you would do for her making a diet plan is take a recall, most importantly. So I'll sit and first understand what she's already been eating. I will not go into the basics of protein restriction and potassium. We all know that, I will just focus on what I would plan for Camila particularly. Okay. So now with the calories, of course, I would give it as per her requirement. And now coming to the proteins, I would understand her recall. Considering that her BMI is 24, I understand she is falling into a normal weight category. She's not overweight or underweight. Okay. So maybe 0.8 if I were to give, of which 50% will be from high biological value. Now the high biological value I will make sure comes from the non-veg source. So the only understanding that I will give her is how many grams of proteins is coming in 100 grams of non-veg. I will explain to her about the edible portion of non-veg, about the portion control for non-veg. I will not stop her non-veg, but of course the portion control will be explained depending upon her intake. That is with regard to proteins. Of course, eggs will be given, and the second class proteins, if she's not very keen, we will adjust more into non-veg. So depending upon her recall, we will finalize that. Coming to the potassium levels are normal. So we will not go into an aggressive restriction. But then again, she's Camila Fernandez. She must be adding coconut to all her curries, you know. So I will just understand how much coconut she's adding to her curries and just calculate, because on an average, Indian diets are high potassium. You know, if you're taking a lot of chapatis and all, so not about the exceeding limit, but then at least I will understand her intake of coconut in the coconut curries and see if I need to replace that or continue with that. Salt restriction, again, because she's a Goan Catholic or a Catholic, she must be having pav or breads for breakfast, you know. So that is a strict no. All the liberalizations on one side, bakery on the other side, you know. Salt restriction is something that I will explain it to her, that it is not because you are a renal patient. On the whole, WHO has recommended 5 grams of salt. So now when you fall into the renal category, it is a little more restrictive. So we will sit and work out. I will not give her upma poha for breakfast, you know, that she'll faint there, you know, if I do that to her. So we will come with options like pancakes or oats porridge, you know, we will come to, you know, generally it's a bargaining session when I have a diet counseling, you know, some points I give, some points they give, and then we come and plan. Like if she wants to have a bread, then we work on sodium-free breads. I have recipes that they don't turn out that good. But if she's keen on dipping it in tea, you know, those breads are hard when you make it without soda. But then if she will dip it in tea and have it, becomes soft. So if she's willing to do that, we continue with that. Or we make pancake with maida, or we make oats pancake. So there is where we figure out a bread. But with all the restrictions, I might not allow her to have bread daily. Everything else will be in moderation, because only the creatinine is high. Everything else looks good. There is no swelling. The urine output is good. So I will not put her on any fluid restrictions. The blood pressure is normal, but again, I will tell her, just because your blood pressure is normal, you can't take normal salt, you know. That is where the notion comes, you know. Sometimes they have low sodium levels and they start taking salt because they feel the sodium level is gone low. So there is where I will sit and I'll explain it to her that these are the points. Again, I will not put her on any phosphorus restrictions, but I will tell her that everything that is rich in protein is rich in phosphorus, you know. I am not putting you on any, in case she does not come back to me for follow-up, she should know what is phosphorus, what is potassium, what is sodium. So when she moves out of my clinic, at least she is educated. So even if she does not come back, she will at least be keeping a track of these parameters. So maybe we might not be that restrictive to the patients if the parameters appear normal. But I feel educating the patient is very important, so that if we are in South Mumbai, if the patient is coming somewhere from the interior, they might not come back. But at least when they go to their general physician, they know that no, my phosphorus was normal 2 years back when I saw Sana. Now it has gone high. So let us look into that, you know. So I feel I will educate the patient, but with regard to the diet, I'll be a little liberal because the parameters are not that high. So that will be my.
So I think a lot of people must have felt itna simple cheez hai. Why is Dr. Khanna brought it out? But I'm a family doctor in nephrology, and I work in the community where I see all kinds of diets being prescribed. And I thought there are a lot of general practitioners, physicians, and some of the community dietitians who must be listening to this, or who would be listening to it. So let's put the dietary process.
I would just like to add one thing. When you're talking of community dietitians, anybody who has a formal education in dietetics, when I say formal education, I'm referring to a BSc program. When they undergo, they are trained on renal nutrition.
Right.
You have a subject, but unfortunately, like how is it is in our country, people do 3 months, 6 months, 1 year online courses, sir, which is for 1 hour in 1 week, and they start practicing nutrition.
Absolutely.
So probably when these people may be able to do the wellness bit, but when it comes to specialized dietetics, they will be the ones who will not be able to guide patients well.
Absolutely. So we do have general practitioners also of that kind. So it's not restricted to only nutritionists. I mean, this is just for everybody.
Yes.
And it's nothing to, you know, talk ill about anybody. It's just that we need to educate everybody, which is what I was talking to Dr. Anita Saxena about. When we do these SRNMCONs, why are we trying to include all of it? Because nephrology is not practiced only in corporate and PG, teaching hospitals, but also in the periphery. So I think we move on to the next aspect, and we are going to take all these together. So Arvind is there, and what is the science behind restricting proteins? Why do dietitians or nephrologists talk about restricting proteins? And more importantly, is it really needed? And of course, a lot of it is covered by some of the speakers earlier. And how do you advise your CKD non-dialysis patients about protein restriction? You are mute. You are on mute.
Thanks,
Yeah.
Dr. Khanna, for including me in this debate. So nice of you. I would like to share some slides if you're okay with that. Can I?
So we have very little time, so I would be happy if 1 or 2 slides only.
Okay, fair enough. Other participant is sharing.
Nobody will be allowed to share more than 1 or 2 slides.
Fair enough.
So you will have to stop sharing so that Dr. Kanchi can share his slides.
Oh, so maybe Kanchi, it would be better if we just talk about.
Fair enough. Yeah, not an issue.
Yeah.
So basically, the idea of restricting protein in patients with kidney dysfunction obviously has come from Brenner's hypothesis. You're looking at trying to protect the kidney, trying to reduce the decay in GFR by giving less protein, less work for the kidney, and that is the basic premise behind it. But in the Indian context, quite frankly, in CKD patients, I would personally say that I would not stick to this sort of a diet. And why is that? That's because
there is some disturbance in the background. Can somebody mute if he is unmuted except Arvind? Yeah.
Okay. So basically, the diet from the Indian perspective, there are studies that show that despite, I think I hear the noise again, that despite protein restriction, the protein intake of the average Indian is between 0.8 milligram per kg to 1. So you are looking at an already restricted protein diet in most of the normal population. If you take vegetarians, you can decrease that by 0.1, and you are looking at a restricted diet already. Now, if you are looking at the amount of protein taken in by the average Indian, you're looking at cereals contributing to 50 to 60% of the protein. You're looking at non-vegetarian food contributing to about 7 to 10% of the protein. This is even in non-vegetarian people who take non-veg food probably 2 or 3 times a week, maybe more. Bulk of the protein content in most Indians come from cereals, come from milk and milk products. Only 7 to 10% comes from non-vegetarian food. So the question of restricting protein, especially in vegetarians, perhaps in non-vegetarians as well, is really besides the point. There is another aspect to this problem. The other aspect to this problem is that as you starve these patients in the sense that you are now not going to give protein, you're going to reduce their phosphate, which is also has an effect on the protein intake, you are then getting to a stage where as this patient reaches dialysis, he is in malnutrition. He has protein energy wasting, and that is a really big problem because you know very well that in dialysis patients, when you measure the serum albumin, that is the single most important indicator for mortality. And it's been shown in Indians, 68 to 80% of patients who enter dialysis are protein deficient. Now, if that is the situation you have, why are you restricting protein beforehand? Why do you need to restrict protein in patients in a population which is already taking a protein restricted diet?
Can I stop you, Arvind, here? Any of the nutrition experts tell us on your dietary recall, what is the kind of protein intake most people say? Arvind has probably quoted a figure of around 1 gram per kg. How much, Arvind, you said?
0.8 to 1 already in the normal population. I'm not talking
anybody differs? Anybody differs?
No. So we had done a study where we tried to assess the nutritional status of normal people, and the mean that we had got was about 0.65. This was on a mixed diet,
right?
And that is what we had got. I'm talking of a mean, but if you're asking the range, it ranged from 0.5 to 1.1.
So Zamrud Patel is saying the whole country is on a CKD diet. Right. Okay. Anita, you wanted to say something? Yes, quickly.
Unmute, ma'am. Unmute.
Actually, Dr. D. Sinha from Kanpur has published a study which was done on controls as well as on medical doctors, right? And it's published in Journal of Renal Nutrition and Metabolism 2 years ago. And it has shown clearly that the average intake of protein is 0.6 grams per kg body weight per day. And it's not even 8. Even the healthy individuals are not able to get 0.8 grams of protein per day.
Right. So everybody is reinforcing.
Just a moment.
Yeah.
So my question to Sana is, when she says, when the patient comes to her with 3.2 creatinine, she would like to start from point. She's not even diabetic. The patient is not diabetic. Patient is not hypertensive. Nothing, no comorbidities. Just come with a creatinine of 3.2. So why do you want to get into a hyperfiltration? The postprandial hyperfiltration state for the patient. Why don't you keep the patient on the same kind of protein that the patient was taking? You want to go beyond the normal intake, that is 0.6. You want to start from 0.8. I mean, I don't think we would want to burden the kidneys. They're not even used to 0.8 now, particularly with 3.2 creatinine. How can you think of giving 0.8 protein if the patient is not diabetic? That's
no, I think she said that she would do the dietary recall.
Recall. Because I heard Camilla, ma'am. If I would have heard Surinder Jain or someone, I would have said something else, you know. So,
no, I think she said that we will do a dietary recall and then accordingly.
When I hear a shake, again, it differs. You know, when I have a shake or a khan or Camilla, you know, so that way it differs.
Correct. So I think the panel agrees that there will be the need for protein restriction in general theoretically, but the country is already on a CKD diet. So where is the need to alter the protein intake in a large majority of the people? We move on from proteins to phosphorus. So that's another area. We'll move on from protein, phosphorus, potassium, fluid, salt, etc. Phosphate, Anita, what do you think? We have a problem of, do we need to restrict phosphate in our diet? The kind of patients you come across? And then Arvind, you will have to give your
I think, I'll give you our study. We've just finished a study on FGF23, clotho, vitamin D, and on hyperphosphatemia. And we found that even in CKD stage 1 and 2, the FGF3 levels, we know it's a phosphoric hormone, it goes up. Right. So what we did, I told my dietitian that you restrict phosphorus rich foods. So when we brought the phosphorus rich foods down, we found that the GFR went up within a year, and the phosphorus came down. FGF23 came down, clotho levels went up. So when we think of restricting phosphates, we say everything, the serum phosphorus is within normal ranges, so we shouldn't think. But looking at the results, what we are getting now, I think phosphorus restriction is important. But at the same time, if you're giving majority of phosphorus from plant-based proteins, it's not going to be absorbed completely. So it's only about 40% of what is going to be absorbed. Right. But yes, animal protein will have to, I think, should be restricted. The flesh part should be restricted. Yeah. I wouldn't want to restrict milk or egg. Egg is a very good friend of our CKD patients because the lowest phosphorus to protein ratio. So not that at all. But definitely, when it comes to, I've been thinking about it. We've published we have 2 publications already. Third is also coming. That phosphorus restriction should be started right from stage 1, but it doesn't mean that the patient has to suffer. What Mr. Kamal said is something so very painful that dal of thin consistency. That's what we hear in the OPD all the time, and it is so painful. And see, this is the reason SRNM. This was the thing that I wanted non-physician nephrologists to know, non-nephrologist physicians to know, that don't say zero protein and don't give them liquid dals. They give them something which will maintain their muscles. So this is the reason why I try to reach the physicians who are not nephrologists. Just because the patient, when he comes to us, is oddly shattered, is totally badly psyched that he can't eat this, he can't eat this. This is that particular doctor said no, and you were saying you do that. So this is the reason why SRNM is
yes,
important.
We are thankful. I think it was very important. Arvind, you mentioned about the Indian diet, even in non-vegetarians, is hardly non-vegetarian. So are you in your practice restricting phosphorus, or you are kind of allowing them normal food? Like what Samir and Kamal, if they come to you, you will allow them what kind of food?
I would allow them normal food. And here's the reasoning. The reasoning is that, yes, phosphate restriction is needed. Perhaps you're looking at the calcium phosphate product, you're looking at the PTH going up, you're looking at FGF. These are all numbers. What is phosphate restriction going to do? phosphate restriction means you're going to restrict some form of protein again. If you start restricting protein, you're contributing to mortality. Has phosphate restriction or phosphate binders, have they ever shown a decrease in mortality in CKD or dialysis patients? The answer is actually no. There are 2 trials ongoing, randomized controlled trials, the high-low trial and the phosphate trial. Hopefully, they'll give us numbers. We have plenty of prospective trials. We have plenty of retrospective trials that have shown that phosphate restriction, phosphate binders, perhaps non-calcium phosphate binders are useful in reducing many of these numbers. But does it improve the important fact of mortality in these patients? And the answer is no. When that is the case, you are now going to restrict all these things, given that the patient is already on a low protein diet, a low phosphate diet, a low salt diet, a low water, and like our patients on dialysis say, they're going to get to eat nothing. So I would not restrict it I would not restrict vegetarian protein at all. Never.
So overall, in Indian context, what you are saying is that there is not a great need to go down to low phosphorus diets and maybe allow everything in moderation. If at all an occasional patient has phosphorus issues, we can use phosphate binders. Is that what your conclusion would be?
So the point is that if you're looking at colas and other food that contain additives, you would want to restrict those sort of phosphates.
Sure.
Obviously, if you're looking at protein food, you have to be a bit more careful in looking at that. Right. There's no doubt that a high phosphate level contributes to mortality. There's no doubt that a very low phosphate level contributes to mortality. The question is, does diet intervention plus phosphate binders reducing the phosphate level does that help mortality, reduce mortality? That is yet to be shown.
Right. We have 15 more minutes and we have come down to 2 problems. Protein restriction, not required to a great extent. Phosphorus restriction, not required to a great extent. I hope the 2 patients are satisfied that we are trying to be patient-centric rather than the figures or the value-centric. We move on to the fluid restriction part, and I think
Dr. Umesh, can I say something?
But 15 minutes and we have lots, so it will have to be quick.
Just a minute.
Yes.
See, protein restriction is not required because they're already on low protein. And even for a dialysis patient to reach 1 gram is, earlier on it was 1.2, last year it's come as 1. So 1.2 was really difficult for us to be able to, get the patient onto 1.2, but at least 1 was 0.8 and 1 something between that. What I'm trying to say is, I said phosphorus restriction is important. You just have to change the kind of, vegetables the patient is taking.
Correct.
I'm not asking you to restrict protein at all. Correct. A lot of phosphorus comes from nuts. A lot of phosphorus comes from vegetables. Right. So that is the point that my dietitian, she's just swapped, the kind of the vegetables the patient was, and it showed the difference.
So you can
not that restricted protein at all. Never. That's not possible.
So you're saying other kinds of phosphorus should be reduced.
Can I just add that vegetarian protein?
I think the phosphorus debate can be taken on a separate level. We are now at fluid, unless we want to only stop at phosphorus, then otherwise, so I want to cover up almost all the points. But I think the point is well taken that phosphorus restriction should be not at the cost of protein restriction, but at the cost of all other sources of phosphorus, which should be changed so that the patient has the benefit of it. So fluids, I think the 2 patients have already highlighted, is a big problem, and they are asking the dietitians to try and help them in how to manage fluid restriction. Sana, Zamrud, anybody can take it. Methods to handle fluid restriction, in short.
So in short, I will just say that when we are talking of fluid restriction, first thing is that we train our patients to, if they are non-diabetic, so you have these candies which are, fruit flavored candies that you get. You keep sucking on these candies, which quenches your thirst. Or probably even we have we have ice trays available today, which is with a mark of the ml that 1 cube would be making. So you can actually set those trays, so 5 ml per cube. So you can make that, and instead of drinking water, probably you can suck on these ice cubes, which could be flavored with a ginger juice drop, or lemon juice can be added, and that really helps the patient. Probably even for dialysis patient, many times we say that have thicker dals, have thicker curd, so that you can, save on little fluid that can come. Or probably instead of adding milk, you use paneer. These are some practical things that we normally train our patients to do to save on the fluid.
Right. And some of the patients find their own ways of doing it, like how
Yes.
Samir and Kamal has done it. Yeah, potassium, this is what I call as a do dhari talwar. And, either way, we've had a couple of topics on why restricting vegetables, fruits, etc. may not be a great idea. And in many patients, except for a few in whom potassium is a big problem. So there is the good, the bad, and the ugly part of potassium, and we all know about it. And we need to, as Kamal says, go around it rather than, strictly restricting. So, Arvind, good part of giving potassium, why we should not be very strict with vegetable, salad, fruit restriction completely.
Well, obviously, the good part of restricted potassium is the fact that
No. Good part of giving vegetables, salads, and fruit.
Yeah, good part of giving potassium would be that it has a blood pressure lowering effect. We know that the DASH diet has a lot of potassium in it. Not only does it have a natriuretic effect, it has a renal, it has an adrenergic outflow decrease effect, and so it has a vascular tone effect as well. So definitely I would give more potassium in certain individuals. There is a beneficial effect in reducing stroke. This has been well brought out in trials. Some of these effects may actually be independent of blood pressure lowering.
Arvind, most of the noise is from your end, looks like.
No, it isn't.
Okay, fine.
I've got a very clean laptop.
Yes. Sorry.
Yeah.
Please go ahead.
Right. Bone homeostasis. If you look at giving potassium, bone homeostasis is quite important because food enriched in potassium actually gives you a base load. And that is quite important. And high potassium may actually have a direct effect on some of the bone metabolites. Kidney stone risk is decreased. I think you may have heard the talk yesterday, excellent talk on how potassium helps. A decreased progression of chronic kidney disease. There are a few papers that show bioavailability of phosphate is decreased when with plant protein, and when you give plant proteins more, that helps, decreased progression of CKD. So there are a lot of effects of increased potassium in the diet that you would want to keep potassium high in the diet for most of the population, I'd say. In CKD, obviously, we're going to have to be a bit more careful, and
actually, I wanted you on CKD only, basically. What advice would you give to your diet? So we go back to the dietitians. So let's take Sana first. Are you permitting salads and green leafy vegetables and occasional fruits in people? I don't know, in people whose potassiums are reasonable, and what level of potassium are you strict?
So when the potassium levels go above that is the checkpoint we follow at the clinic. It's Dr. Ashok planning. If it goes above 5.1, 5.2, that is the only point when we get very strict. Even at that point, we have never stopped the low potassium fruits, which are the CAP-TO fruits, because then the patient feels highly deprived. If we were to give salads at that point, when the potassium levels are very high, we give them leached salads or boiled salads. We are always coming up with solutions. Maybe leaching might not, and we explain it to the patient that is not making the diet potassium free. But then we are trying to give you a favorite food with potassium restriction. So if the patient wants to have curry, we will ask him to have rice flour curry. So that is how we manipulate only if the potassium level goes above 5.2, 5.2.
So unfortunately, a lot of patients will have potassium around 5.1, 5.2 CKD patients, especially many of them are on AS, ARBs, etc. and so on. So in which case, between green leafy vegetables, salads and fruit, which one is more likely to be permitted by you?
Depending on the patient's choice, like I said, what you want.
So give a choice.
Green leafy vegetables, generally, I would prefer not to restrict. If the patient is agreeing, once a week, even with high potassium, we allow leached green leafy vegetables, slightly leached the green leafy vegetables. And fruit is, at least the low potassium fruits should not be restricted at all, I feel, because then the patient is, if the patient is diabetic, call it the patient not having sweets, the patient is restricting other things, and then fruit gives them that satiety, the feeling, it makes them feel good. So the mid-morning fruit, at least we don't restrict, even at the highest potassium level. We try to manipulate the rest of the diet, but try and squeeze in the fruit wherever we can. Only if the patient doesn't want it, we will not give.
So Samir Haladi comes from Ratnagiri, and he has a mango farm in his place where he stays, and he's really upset about it.
I'm from Mangalore, yeah, but
it doesn't matter.
we
2
do
minutes
love-
ke liye Ratnagiri mein reh jana yaar. What is your problem? So anyway, is there a way we can move around it, so people who like such things, and like Punjabis, they will be mad at the fact that you are stopping dry fruits. Uske bigger life kya hai? What is the point in living? Yeah.
So, sir, I'll just highlight over here. See the pattern of dry fruits, the way we eat. Normally, we soak our dry fruits and we eat. Most of the people. So actually, when you are soaking, you are doing the leaching part.
Yeah.
And again, the portion size. If somebody tells me that when I have to ask in the recall how many grams or how much dry fruit you are eating, the answer is 5 badam bhigo ke khata hu, raat ko bhigota hu, subah khata hu. So you don't need to restrict that. Again, coming to that question of yours on Ratnagiri Hapus. Sir, if you see, we have the new version of our nutritive value book, the IFCT book. In that, now we have around more than, I think, 50 varieties of mangoes which are evaluated for the potassium content. And I don't know whether you heard of this Totapuri mango.
Yes.
Yes. So that
but
has
nobody
a lower.
eats.
Yeah, but actually it has a lower content of potassium, and probably even hapus, if you're controlling the portion size and you're giving, and if I'm doing my diet recall and I'm doing my calculation, probably if I'm able to balance it between, when I'm giving a 40 milliequivalents diet of potassium for a patient and I'm adding that half mango, if I'm adjusting in my requirement, I think the patient will be satisfied and will be able to do justice. Because I believe that if you go make the diet plan as per the patient's preference, there you really help the person, and that is what is a job of a nutritionist. Not writing no's, but we always prefer to write the do's. That's most important.
Excellent. So I think in your party which you are going to throw at the end of 2 questions, I think Totapuri might be around. So let's see. Anita, this question is important because some of the children have a major issue about how do they, at that age, they don't want these kind of restrictions. In your department, do you face issues of children rebelling against these dietary problems, and what kind of issues?
See, when it comes to handling the children, we don't really get many pediatric patients in our department, but then we do have a little bit of experience. And then, as I said, with children, we do not like to restrict much. And as I said, even for when it came to nephrotic syndrome, straight away, I'm always thinking whether to go for it or not. But in CKD patients, definitely everything has to be according to their RDA. So you can't. But definitely, if the patient is moving towards hyperkalemia, then you would have to restrict fruits no matter what. And if the patient has, I think our kids are doing pretty well, so we don't really come across so much of a problem. But then they have to be counseled on how to avoid taking crisps and all. These are the things, the fast food. And then the only thing that I when I talk to the kid, and I just tell him that you be the leader, these things are not good for health, so you tell your friends not to take them, so that he thinks that, well, this is really, it is a very good, he can be a leader, he can bring about so that is, but I didn't think we tackled so many kids.
Yeah, but it's a good point you made, that counseling the child is important and making him realize that
I always tell him, I always tell the mother that, look, if he follows what the dietitian is telling, and if he follows what I am telling, then on every such and such day you give him a reward. So they are rewarded. I tell my kids, my patients' mothers, that you must reward your child for behaving so nicely with you. I mean, not being so you have to handle the psyche of the child and the mother. So I think that is the way I do.
So Kamal, do you feel like eating बीच में biscuits, cake, pastries, ये dietitian को छुपा के side में बैठ के, is there a time when you want to cheat on them?
Absolutely. I love bakery products like a veg puff or a cake, and on a birthday, for example, but I kind of feel very scared when I'm about to eat it because of the diet restriction, but I would love to eat it.
So Sana, how do you handle people who are alone or do not have the luxury of having people to make specific snacks which we prescribe as dietitians. How do you handle these people?
So, like Dr. Anita Saxena said, we have this reward days for adults. I tell them that Monday to Saturday, they've been dying to have a cake or a piece of pizza. You cannot say strictly because this is a long-term thing. They'll keep on this for a very long time. So we tell them, Monday to Saturday you follow the diet. Maybe on a Sunday you can have a small piece of cake or a small piece of pizza. Portion control is more important. This works for adults as well. Apart from this, we will have other options like we will ask them to make on a weekend. Maybe they can make a roasted poha chivda or a roasted kurmura chivda or roasted jowar puffs. That way, or we come up with recipes like rice flour shakkar para, rice flour chutney. We have all the recipes written. Depending upon what the patient wants and how he wants, we come up with solutions. But then we do have certain cheat days, and sometimes we modify the cheat. Like if they really want to have the pizza, we look at the topping with paneer. We make the base with arrowroot, that way. So we formulate recipes for patients. We come up with ideas, so that way they don't feel deprived. But nevertheless, if they want to visit Domino's with their friends, maybe a youngster who is 21-year-old and is battling CKD, on a Sunday maybe, but then we educate them about portion control. Then we tell them that you can go, but portion control is very important. Don't have coke with it. So that way I have messages almost every Sunday, that I'm going to this place, I'm going to this place. Then I come up with ideas what they can have. If they're going to barbecue nation, I have ideas like I'll just try and figure out what they can have there. You cannot always say a no. Then they feel then they have withdrawal symptoms. Then they don't trust in you.
So I think we are almost reaching the end of it, and therefore Zamrud is throwing a party for CKD patients, and all of us are supposed to barge in. Zamrud and Sana will make the menu. Sana will handle the kids whose birthday celebration is there, and Zamrud will handle the adults. I don't know Daru is allowed or not in that party, but we'll come to that later. Yesterday was a dry day. Today I think it should be allowed. Zamrud and Sana, it's all yours. The stage is there for a party. Let's celebrate.
So if you ask me, sir, I have really worked very closely with patients, and now I have started working very closely with caterers, because we realized that a lot of people need restrictions. So now probably we have started developing menus for parties. So you all are welcome. We normally work with these caterers. We give them the recipes. For example, as Sana was already highlighting, we get the pizza bases made, we get the toppings done. So probably, as we've already discussed about the protein restriction, we do not have to use much for Indian people. So we do use cotton cheese, or we use cheese for our pizzas. Again, we have a lot of roasted snacks that we are making today. And in the market, unfortunately, you do get roasted snacks, but that is not the minus the salt. But at least at Mumbai, if you approach a Cheda store, which is a chain of stores, and if you give your orders for a salt-free snack, because many times you don't need roasted snacks, you need the normal snacks, but only thing is the salt needs to be modified. Probably for most people, you can order these snacks today. So people who are staying separate, or who are staying alone, you have options today available, and you don't have to feel deprived. You can modify everything. It's very easy to modify. Only thing is we need to understand what are the likings of our patient, and yesterday that was the reason of doing the regional diet menus. Region wise, we are very specific with our foods and spices. So if we are able to modify that as per the liking of the patient, I don't think we will have any patient cribbing, and we can always enjoy parties.
Yes, I think Sana, we are about to close, but this child has a birthday celebration, and the mother says, "Khali idli leke jao school mein." Can he? And all the other kids have taken cakes, pastries, etc. Abhi kya karne ka? What do you?
So
Sana, you're muted.
At present, I'm already handling a case. The other day I was talking to him, and he's telling me, "Yeah, restriction." I said, first of all, get the kidney disease out of your head. You are a normal kid. Now tell me what you want. What you want to eat, and I will modify it. Everything from idli chili to paneer chili, everything. Chicken chili, whatever you want to eat, I will modify it. I will minus the sauces and use the spices. I will minus the base and use arrowroot. Whatever, I will first make sure that the kid is not treated as a renal kid. It is very sad, to see kids being called as patients. So first, get it out of your head. He was so happy, and he said, "I want French fries." I said, "I'll go ahead. I will make that for you. I will leach the potatoes. I will do that for you. But tell me what you want to eat, and I will modify." That is the role of a dietitian. To modify the diet. That is where the talent comes in.
I think beautifully put in. I always said that Sana has that knack of, being practical and things like that. So I think I will not give the summary. If any other patient wants to have one, half a minute to finish, because it was a patient-centric talk. So if you feel you want to add any points, both Kamal and Samir, as to what advice do you have for nutritionists and nephrologists about handling patient-centric diet? Otherwise, I think.
Yeah, can I come in?
Yeah, please.
So I think the bottom line of this topic is give workarounds rather than blanket restrictions. Like Sana just said, if they want to have, figure out, like even Coke, for example, right? I'm not saying that let them have 1 liter or 300 ml. Let them have 100 ml, restrict other things on that day till the next session, right? So workarounds is what should be given rather than blanket restrictions. That's all I would like to say.
Very good point. I think with that, we close. And first of all, I apologize being a little rough and, just basically because we wanted to cover up a lot of sessions, a lot of topics, so that the topic becomes relevant to whatever is given to me. And I must really thank, it's very difficult to be a panelist. It's easy to be a moderator. And thank you so much for so exceedingly well this whole topic has been covered. And I hope we've done justice to the topic. Thanks.
Thank you.